So very quickly, I have sleep apnea. I've got severe sleep apnea. That's my AHI. A dentist transformed my life, actually, because I was snoring and I needed a sleep mandibular advancement mask, but had a boil and bite device. And I think it was Harry Ball. And he said, look, you probably have sleep. You might have sleep apnea. I was like, don't be ridiculous. Don't have sleep apnea. I'm a snorer. So then I had HI, which was really high. The next day, when I used the CPAP machine, I was working as a registrar at Monash, and one of the bosses came up to me and said, look, I don't mean to be rude, Ryan, but you look like you've had a really good night's sleep. And I was like, oh, okay, well, it's funny you should say that. I look tired. He goes, yeah, you do. And I said, well, I've actually been using a CPAP machine. He said, well done, because, that's really important. I didn't feel any different for about a week, and then I was just amazing. I could sleep for 3 hours, and that's all I needed. Obviously, that didn't last, but I'd forgotten what a good night's sleep was. And so even though I don't like using the machine, I am actually planning some nasal surgery to improve my compliance to use the machine. It's really life-changing thing. So that's my sort of interest. This is Donnie, who talks about the importance of mouth, the nasal breathing. So this is, I think I said this earlier, why do dentists matter? They're the first ones to spot the airway red flags. They're talking to the patients all the time. They're taking the time. They're working with myofunctional speech therapists, or some of them are. And, I think generally speaking, they know when to refer. So ENT's role in the airway. So we are part of it. We're not the complete package. And I don't think we necessarily should be the ones driving it either. I think, we were taught that we should be leading the MDT airway team, maybe, I think, but not necessarily. I think a good general dentist who has an understanding can refer to the ENT, can refer to the lung respiratory doctor, can refer to the orthodontist, myotherapist. I think that is, you're almost like the GP, the general dentist. So assessment of the airway, that's the procedure, part of the procedure. And parents often have videos, very helpful, oximetry when appropriate. So this is a picture of, this is amazing. Like, look at this, it's gone 1 centimeter wider this distance. And if you look in the nose, there's two nostrils. I don't think I've got the coronal view, but you can see the nasal width has increased like by 0.5 centimeter on either side. Yeah, so like 0.5 centimeter, that's pretty good. Like, the turbinates, if we reduce the turbinates, we're going to get like less than 0.5 centimeter. If we straighten the septum, we're going to get less than 0.5 centimeter. So just by doing that alone, you can see, wow, this is, you don't really need research, randomized controlled trial studies. This is clear, but that it must make a difference. And now Derek has published his PhD on essentially this, which is sort of validating, oh, well, no surprise. If you widen that airway, the sleep apnea is, they're not going to get sleep apnea. So adenoidectomy removes adenoids, tonsillectomy removes the tonsils there. Turbinates sit here, they're like little sausages, and they mainly block the front of the nose. Laryngomalacia, not very common, but sometimes floppy epiglottis can be a cause. We don't want to operate on the septum in children because they're still growing, and you could result in a child that's left with a child's nose by the time they get to an adult. That's the theory behind it anyway, so we generally don't operate on the septum. Non-surgical management, medical therapies, medications, nasal steroids, antihistamines. I've added here the vitamin O, vitamin M, which is a more expensive version of the GLP-1 receptor agonist. I think losing weight can make a huge difference in patients' lives in regards to so many things, as well as sleep apnea. Mandibular advancement splints, CPAP, and then, treating nasal congestion to improve the compliance with the mandibular advancement splint and CPAP therapy. So, I find a lot of patients, if they haven't been treated holistically, they've had a sleep study, and then they've been given a CPAP machine, or they've been sold a CPAP machine, but their nose is terribly blocked. So how are they going to use a CPAP machine? They have to use a full face mask, which is very uncomfortable. It blows air in their mouth. They might have a beard, and then so it's leaking, and they throw the machine away. It's just a waste. And then they see an ENT and say, well, this is the reason you didn't tolerate the machine. Your nose is blocked, your septum is blocked, you've got massive tonsils. Why don't we do this first and then try the CPAP machine in that order? So, talked about the septoplasty already. Adults and children, they're very different. I think, well, they both have allergies, but adults often have more issues with reflux. In children, we're more conservative. We just like to do the adenoids. If you're under 2 years of age, we really, really try and avoid taking out the tonsils. If you're under 4 years of, 2 to 4, you consider it. and turbinates is a very safe operation, generally speaking. Whereas in adults, you can be more aggressive, operating on the septum, and the turbinates, the tongue channeling. Weight control is often an issue in adults. So in children, you have to cure sleep apnea. No amount of sleep apnea is normal in children. Whereas in adults, you're kind of just trying to often improve their sleep apnea. You can't cure everything. They've already missed the boat. Their faces, without going with really massive surgery, it's more about control. So this is a collaborative approach. We sit down table, we're all equals, and we all have something to bring to the table. So yeah, feel free to, if you have any questions for myself or Derek. Yes.
Sorry. So with the middle ear getting blocked as well as part of the symptoms, so would the kids having history of grommets inserted be a red flag as well?
Yes. Yeah, I think so. If they've got like middle ear disease,
yep,
it is often associated with adenoid enlargement. And even if the adenoids aren't enlarged, by removing the adenoids, that reduces the chance of the grommets being needing to be reinserted. So
yep,
definitely.
And with the frenectomy, I've heard people saying, "Oh, you just snip them and that's it." And other people were saying you need to do the muscle reattachment, muscle reorganization as well. From the ENT point of view, do you need the muscle rearrangements, or simple snip is going to do?
I think it's hard to assess when they're awake, but when they're asleep and you really have a look and you feel in there, it might not just be a simple, like fibrous sort of anteriorly, but more posteriorly, there's like a deep band of scar tissue.
So it's case by case.
And you have to be case by case. So.
And with the speech therapist post-op, would it be the ENT that refers to the speech therapist, or would it be us or
ideally, they would have seen a speech therapist before they even have their treatment. So they've already been getting exercises, trying to get as much as they can with their tongue tie, and then deemed that it's not enough. And then they would see the ENT surgeon or a dentist who would do it. And then afterwards they would continue the treatment.
Yeah.
So they would have been worked up for I had a patient who had a tongue tie, and I said, okay, now you've got to go see the speech therapist or the myofunctional therapist. And they didn't see them for 2 weeks afterwards. And it was like, they'd already missed the boat. The tongue had already started to scar. They didn't know the exercises. So it's almost like speech therapist said, no, you've got to get them before pre-surgery and post-surgery.
Yeah. So is that done by us or the?
I would do it as an ENT. I'd be happy to do it, but if you had someone that you trusted, be definitely good, because it can be hard to get an appointment to see the speech therapist. And the parents often want the surgery sooner rather than later. So, yeah.
Really sorry, one last question.
Yeah.
So if we refer to you regarding the airways, is there any Medicare subsidies, or is that fully private compared to the GP referral?
Well, as a consult, there's no Medicare, there's no like private rebate. So it's the same if you're uninsured or insured. And if you were seen in the public clinic, there'd be no charge, but then it's just the wait to be seen.
So
and yeah, it's pretty much the same. And I think with the sleep studies for adults, if you qualify on your Epworth sleep score and your stop bang, and most people do, then they get a Medicare subsidized sleep study, but it doesn't really cover everything.
As a dentist, you can refer to ear, nose and throat as a Medicare rebate.
Oh,
yeah. But as a dentist, you can't refer for a sleep study for any Medicare. You have to go through their GP.
Yep. Thank you very much. Thank you.
Somebody's asked, what position is best to assess the airway? Tonsils, patient laying down or patient sitting up during a dental exam? Well, that's a good question. Yeah. So what position is best to assess the airway? So I think like when somebody's sitting up, everything's kind of like in this anatomical position, I guess, and everything's, and when they lie down, everything collapses. So I would say, look, the best way to do it is to do it sitting up and then lying down, and then put them to sleep, but not a drug-induced sleep, but an actual natural sleep. That's unrealistic. But I think I'm just talking about my personal practice, I would generally not lie the patient down. But I would look around with a nasendoscopy, because when you look around the corner, around the palate, and you see that the palate is already touching the posterior pharyngeal wall, when they're sitting upright, you know, that when they lie down, it's like, it's going to be really even worse. Or the tonsils that don't look that big from the front, then you look down behind and they're like, you're just seeing the tip of the iceberg, and they're prolapsing posteriorly. And what will sometimes happen when they're asleep and they're having their adenoids removed and they're relaxed, the tonsils are huge because they've relaxed and they've just popped out. And so it's, you know, it can be a bit misleading, the sort of tonsil grading system. So I would say, like, it's probably best to do both, but from a practical point of view, most people don't have a bed in their examination rooms to do all of that, and kids wouldn't be that compliant. So you just have to do as much as you can. Yes. Say that again, the night.
That helps to stimulate some
Yeah. Is that popular in Asian countries? Okay. Okay. Yeah. You know, not knowing that we use lasers at ENT for some sort of things, and, you know, I wouldn't like discount all lasers, but I'd be cautious. You know, I'm half Filipino, and one of my family friends, she's saying, "Oh, I bought this laser from the Philippines, you know, a million pesos, you know," and it's just like this device that is like a little stick which has like an LED. And I was just like, Auntie, this is like a scam. You know, and I looked at it and I think, oh, wow, this thing actually exists and this is a known scam. So, like, yeah, I'm not sure about that laser, but hopefully it's not the laser that, you know, that they just pointedly.
University of Ferrara, laser called a photon laser. Expensive as a 25 correctly, does help, but every 6 months you've got to go back. So in the old days, they would do a U triple P, long term that's not successful. Right? So
Yeah.
it's not surgical insult, but yet like, you know, if you're sailing, sails are flapping, you pull pipe from the sails, that's what that does.
Yeah.
Give you a reference, but it's actually well researched.
There are some old school surgeons who might do the laser assisted uvuloplasty, where they're essentially stiffening the uvula. But again, that the long-term studies, so no one really does that anymore. Yeah. Say that again. Yes. Yeah. So when you've got a deviated septum, the airflow is sort of turbulent and on one side, and I think Pessoa's law, radius to the power 4 airflow. So minor changes make a lot of increased like friction velocity. So the narrow side is often always the side of nosebleeds. And then some patients, the nosebleeds will never really stop permanently unless you straighten their septum. So yeah, and also it's sticking out, they're picking the nose. The people who have nosebleeds are little kids and adults, because the little kids pick their nose and the adults, they're on aspirin, or they get really old, they get demented and they pick their nose, sort of things. I think, yeah, bleeding is something that we'd see a lot, but also you'd also be a little bit worried about von Willebrand's disease. 1% of kids, and nasal bleeding can be a sign of that, or HHT is another condition, presents with nosebleeds.